just think about it. I mean, healthcare is so rife with data. It's not necessarily about collecting more data. In fact, globally in 2025, mankind will generate about 180 zettabytes of data. Now, I had to look this up, but it's basically the equivalent of digitizing all the books ever written and then doing that 3.6 billion more times. That's how much data the world generates today, and healthcare represents about a third of that.
Welcome to Beyond the Blueprint, a podcast designed to empower healthcare professionals, enabling them to improve care delivery through integrated design and technology innovation. My name is Greg Malkery, and joining me is my co-host Keith Washington. Whether you're redesigning a hospital, launching a new digital initiative, or just curious about the future of healthcare, then you're in the right place. Let's explore together what's possible when we go beyond the blueprint. Well, today we're excited to explore the transformative world of centralized surveillance and virtual care. Our guest speaker is Angus Douglas, a nationally recognized thought leader in healthcare technology. He's also the Chief Solutions Architect within GE's Healthcare's Patient Monitoring Division. Angus, welcome to our webinar. Would you like to start by telling us about your background and how you got involved in the field?
Thank you, Greg. So I'm the Chief Solutions Architect at GE Healthcare's Patient Care Solutions Division. I've worked in healthcare since 1988, a long time, across a broad array of roles and companies, ranging from startups in the real-time location industry to patient monitoring to IT systems. And for the last 10 or 15 years, I've been at GE, leveraging innovative digital technologies that address healthcare challenges around clinical alarm management, access to critical data in the moment, and caregiver communication and collaboration. And as a result of these efforts, we've created a number of different successful solutions around centralized surveillance, the most notably being what we call the digitized central monitoring unit, where we've engaged with over 75 major healthcare organizations over the past 5 to 7 years, deploying enterprise-wide patient surveillance.
Great. Thanks, Angus. Keith, do you have any opening remarks for today?
Yeah, Greg. So just a reminder about Beyond the Blueprint. So we try to bring together thought leaders to explore innovative design to help organizations manage complexity. We believe that a good design really helps align organizations around their core mission, that good design also promotes flexibility and transparency and collaboration across an organization. We like to talk about opportunities and challenges and really just create a conversation about integrating and co-creating systems that help empower staff and patients. And we hope this platform will help our listeners and have some to offer some insights on how to navigate the complexity of change and help align care teams and really focus on effective ways to use technology such as virtual care and using systematic design. So I think I'm excited about today. I think it's a great example.
Great. Thank you, Keith. Now, before we dive into our discussion, I want to express my gratitude to our valued sponsors, Storage Systems and Simplified Medical. So with that, why don't we get started? Angus, maybe we can start by just some fundamental definitions. What exactly is centralized surveillance, and why is it important in today's healthcare landscape?
Well, Greg, centralized surveillance means a lot of things, right? And over the past 8 or 10 years, we've observed this sort of quantum shift across healthcare toward virtualized models of care and enterprise hub and spoke surveillance. And these initiatives have many objectives, but principal among them are patient safety, reduction of staff fatigue, especially around alarms, and standardization of care. So I'll give you a couple examples that are the most prominent. The first one, I will say the Central Telemetry Monitoring Unit, or as we call it, the CMU. This has been around forever, but lately we've seen, and say in the last, again, 8 to 10 years, we've seen the scope of these operations grow from being unit-based to hospital-based and even enterprise-based. In fact, we're working on a nationwide project today with Common Spirit Health to connect all of their hospitals across the country back to a central surveillance operation in Arizona. So generally these are telemetry first, but we see folks rolling out ICU and telesitting and home monitoring in that same operation. And in a typical CMU, monitor techs are remotely watching real-time traces and vital signs from anywhere from 40 to 60 patients each. They filter out artifact, they relay alarms, and they get rid of the artifact, repeating alarms, insignificant events, so that they can identify the alarms that are truly actionable by the caregiver. And then not only do they dispatch those either by voice or messaging or some vehicle, but they also have oversight to the alarm process. Because often nurses are dealing with more than one thing at a time, and sometimes they don't get to the lesser priority events that end up becoming more important. So CMUs address really two major problems that are often in conflict with each other. One's alarm fatigue, right? How can we reduce the overall burden of alarms on nurses? And we typically see 50 to 80% reduction of alarms sent to caregivers when people deploy this surveillance, which is huge. But the other part of this is around patient safety, and that's where the monitor techs, their job doesn't end, it really starts once they've dispatched an event, because they provide oversight to alarm response. If an event is not resolved within a particular time frame, the monitor tech will intervene or escalate to make sure somebody gets to the bedside in a reasonable amount of time. So the challenges around this type of operation are cost and staffing. The large number of manual tasks that monitor techs perform in terms of monitoring the beds, looking up who to send an alarm to, communicating the alarm, tracking the response, it limits the number of beds they can monitor effectively. So at GE, what we did is we developed several technologies that we integrated to automate these processes to allow techs to monitor patients with greater safety. This not only saves hospitals in terms of staffing, but it's resulted in tons of benefits to patient care, which we'll discuss during this conversation. And on the nursing side, we also developed mobile technologies to better link them with that remote surveillance operation and also put more information in their hand on a smartphone in the moment they receive an alert. So that's central monitoring, and that's been out there. The second one has also been out there for some time, and that's the tele-ICU. And that's really surveillance for your critical care patients, where we have remote intensivists and nurses and sort of another level up of clinical folks. And they monitor real-time monitoring, clinical decision support tools, and they even have audio video to the bedside to help them communicate with caregivers and patients at bedside. And the benefits of tele-ICU include addressing the shortage of intensivists and enabling faster interventions. And by accelerating clinical decisions and interventions, tele-ICU can potentially impact both mortality and length of stay. Now, more recently, we're seeing virtual nursing take center stage. That really means a lot of things. It's somewhat a nebulous term to me because in a lot of folks' minds, that means tele-sitting, which has been out there, where somebody remote is watching video around patient falls, IV line integrity, ulcer prevention through turning patients, and they monitor patient movement and position. But the second area that's really also been growing is clinical operational support. So what can we offload from that nurse at the bedside? And that's typically around admit-discharge workflows, patient family education, all the kinds of care coordination. So that's really taking tasks away from the nurse at bedside to free them up to focus more on the patients. But then the third area, and this is where we get a lot more involved at GE, is we're seeing a number of organizations implement an additional layer of experienced clinical oversight to kind of not only monitor, but even quarterback the care of challenging patients. And so the question is, like, on this last point, why do we need to do that if we have qualified nurses at bedside? But, after the Great Resignation we saw, throughout the COVID era, we saw a large number of experienced nurses leave the field, both from burnout, but also a number of nurses have aged out. And this leaves us with a nursing workforce that has far less real-world experience than we've ever seen in the field. But these nurses at the same time are also busier than ever. And so the result is caregivers on the floor often miss the early signs of patient deterioration that might have been picked up by someone with more experience or more time with each patient. So we're seeing organizations turn to remote surveillance coupled with kind of scoring systems and deterioration warnings that could include predictive analytics to identify patients who require a closer look. And then these remote nurses can drill into the patient vitals and so on and labs, to kind of see if they need to intervene and even call the rapid response team. So we'll talk a little bit about this further too, but I just wanted to cover the last one of these, which is virtual care at home. And that's such a huge topic because looking at the increasing aging population, looking at hospital capacity, we can't avoid getting patients into the home sooner. And now that we have improved reimbursement and even legislation focused around this imperative, we see several types of operation emerge. One is hospital at home, and that's been significantly shown to improve patient outcomes and satisfaction, rehospitalization, readmission rates, length of stay, and even bed utilization. On the other hand, hospital at home is extremely resource intensive and very difficult to scale. So we haven't seen it grow in terms of the numbers that we'd really like to see. But that brings us to the second aspect of virtual care at home, which is not hospital at home, but hospital to home. And in this case, the hospitals are able to decrease their inpatient length of stay and free up beds while still maintaining their revenue from those patients. And I know what I would feel about getting to go home earlier, and so many patients benefit from leaving the hospital sooner and returning to that familiar environment. And then the third prominent area of home, virtual care at home, is sort of that longer term RPM, as we call it, remote patient monitoring, to reduce readmissions and to provide chronic disease management. So that's kind of a maybe not so brief overview of virtual surveillance.
Okay, well, great description. Maybe we could pivot and talk about when designing these systems, what are some of the key principles you prioritize to ensure you can adjust patient care needs efficiently and effectively?
Sure. So what we're trying to do here, right, with these systems is get constant eyes on patient trajectory, right, eliminate non-actionable interruptions, and offload tasks from nurses, along with that extra layer of oversight. So when designing these systems, right, these types of programs are less about technology and it's more about clinical transformation. Technology, yes, is involved, but we really have to think about designing the workflows and change management to fit the organization. Technology, while important, comes second. So back in 2018, we started to see a lot of interest in the centralized surveillance programs we were able to offer. At that time we were involved with big projects at Beaumont Health, now Corewell Health in Michigan, HCA and Baptist Health and others. And at that point in time, we assembled what we call our outcomes delivery team. That we put the team together to address the clinical, operation, and technical complexities of these programs. And so there's multiple stakeholders and systems that you have to come together to make these programs a success. So here are some of our lessons learned, right? Number one, you got to understand the individual dynamics of facilities and even care areas and what their current processes and roles are. But on the other hand, we don't want to be restricted to current processes. That's the old layering good technology over bad process. Another aspect of this is constant measurement and iteration. So we want to have customer ownership and customizable analytics. So we will give them a custom analytics program in order to help them accomplish their tasks and deal with their hurdles to full adoption. Another area is enterprise standardization. So as we deploy these across large organizations, there are individual facilities and units that kind of want to do things their way or have their settings. But some of the challenges are even small process or configuration differences between sites can cause confusion in a large central surveillance operation, especially as techs rotate between covering different facilities. So we look to have multi-site and multifunctional committees that will determine the enterprise policies and processes, especially around alarm management. We want to avoid the outliers. And in fact, we experienced this with our Common Spirit project that I alluded to earlier, where we had a couple of these outlier hospitals, and that's where we kind of learned this lesson. And so it took pulling those folks into the standardized method of care and the standardized processes to make that really work. So, and then finally, we really try to look at systems holistically, so end to end, and that's where our expertise as a medical device vendor, we can kind of cover it from how the alarms trigger, how we filter them, and how they end up with caregivers on whatever the endpoint they have. So those are some of the things we think about, and all along we're looking for cost out opportunities because these are not inexpensive operations. So dedicated staff, operational efficiencies, how do we scale this effectively are all key.
Awesome. What are some of the common obstacles your team has encountered when implementing these advanced systems, perhaps in some of the larger health systems that you guys have had deployments at?
Obstacles. Well, so I think one of the biggest ones is differing priorities. So we see, multiple vendors involved in these projects, multiple technologies. So I may have telephony, I may have clinical communication, I may have alarm middleware, medical devices, who provides the PBX. I mean, all kinds of different, the EMR vendor. So everybody's got a different agenda. We also see different priorities because we see outsourced IT resources. I mean, EMR build-outs and upgrades can consume the entire IT staff for extended periods of time and affects their focus. The third obstacle would be within the organization itself. Different folks are pro and in favor of these initiatives and some are not. And you have to make sure there's enough leadership to avoid the subtle sabotage by those resistant to change. And the key to all these situations is strong ownership, really driving the change imperative to every department to achieve alignment. We also see things like ongoing user education. I mean, travelers and floats are coming and going. And it's hard, you need to spend time to make sure they understand how this system works. Why did that alarm go off in the medical device, but I didn't get a message? Well, that's because it got filtered out and you don't have to be interrupted. Customers don't often understand also how the change will impact them in the real world until they go live. So that's why we really try to strive to provide these end-to-end workflow analyses so they're really ready and know what to expect. And then finally, there are just hidden processes that are often not even uncovered until we go live, and now we're pulling detailed analytics and metrics, and that helps us bring in efficiencies to light. So those are some of the obstacles we deal with these programs.
Great, Angus. How do you approach integrating technology within existing clinical or administrative workflow processes in order to smooth transitions?
Well, I would say integrating technology for smooth transitions. Well, first of all, you got to strategize culture shift in advance. So, for instance, moving surveillance or monitor techs from on-site to off-site. Maybe once they used to yell down the hall, now they can't do that, or they can't walk over and talk to someone face to face. So they often feel detached from the floors they're overseeing. And then caregivers on the floor, frankly, in the past, they could sometimes ignore an alarm if they were busy, but now everything is transparent. So culture is really important. And so we really need to spell out the benefits to end users. They have to understand the win-win. So yes, you need to address these, but now I'm going to send you 50, 70, 80% less of these events. You're going to get that many less interruptions. So it's hard once someone's looking over your shoulder and capturing metrics. So we need to help them understand the other side of it. And then just governance, right? I talked about multifunctional, multi-facility committees and ownership. So that is, ultimately it all comes down to ownership and keeping everybody focused on the imperative. And we certainly aid them by providing the analytics that help them achieve number one adoption and then incremental improvements as we go.
Outstanding. Well, looking ahead, what trends do you believe will shape the future of this field? And how might emerging technologies disrupt current practices, especially as they might relate to patient monitoring and surveillance?
Well, whenever we talk about the future, right, I have to throw in the two-letter word AI, and just think about it. Healthcare is so rife with data. It's not necessarily about collecting more data. In fact, globally in 2025, mankind will generate about 180 zettabytes of data. Now, I had to look this up, but it's basically the equivalent of digitizing all the books ever written and then doing that 3.6 billion more times. That's how much data the world generates today, and healthcare represents about a third of that. So why have healthcare organizations, move so slowly and or slower than other industries? Well, number one, healthcare data is multimodal. I've got physician notes, images, videos, medical device data, right? So first of all, traditional AI has a hard time making sense of this multimodal data. Second of all is customization. So if I'm in oncology or radiology or cardiology, you know, customizing it and learning it. And every time you have new data, you got to learn and retrain the model. That's expensive and time consuming. And as an aside, one of the things we're focused on at GE is creating what you call foundation models. So that's something beyond kind of the typical generative. It's special machine learning models trained on broad data sets, imaging and waveforms and so on, but fine-tuned to specific tasks. So our first release of of foundation models is a whole body foundation model for radiology, with much more to follow. So then people can use the work we've done and save time and effort, as they try to leverage AI in their day-to-day work. And then the third thing that's kind of kept healthcare from adopting is reliability and explainability, right? I mean, it's one thing to use AI to automate documentation or other operational tasks, but are we really ready for AI to suppress alarms or make treatment decisions? So AI is susceptible also to hallucinations. So it needs to be trained to mimic the way a doctor would search at trusted sources. And the process has to be traceable. So we see something called agentic AI that goes beyond large language models and can operate autonomously. So again, we're working on an agentic AI partner that can propose care plans, monitor progress, orchestrate appointments. That's kind of our vision for the longer term future. So how do we harness that going forward? Well, think about the challenges clinicians face today analyzing data from these multiple sources. It's overwhelming. So leveraging AI, how can we leverage that to help us make sense of information? First of all, in clinical, right? Because AI holds the promise of moving us from reactive sick care to preventative care on a global scale by analyzing data in real time. We see it in imaging today, right? The AI programs in imaging have really moved forward rapidly, but also precise and accurate assessments of disease, and predictive insights. And that's where that fits in, the predictive part of this around patient deterioration, ventilator management, and really anything you can think of can apply to surveillance applications, because we're essentially conducting population surveillance. So predictive AI can be used to bring certain patients to the forefront across a population earlier than traditional early warning scores. We could also look at it for improved clinical decision support. What we used to call the wall of knowledge could be enhanced, through meaningful insights of aggregated data. And then operationally, we also see these technologies being able to use around staffing, to identify efficiency losses, health equity, and even quality of care. And in surveillance, I think about, identifying coverage gaps, right? Where are we seeing delayed caregiver responses, and maybe are they experiencing alarm floods, which I think it was Amy defined as too many alarms in too short a time period. So where are the hotspots in the organization where maybe we need to apply more resources or assistance? And also around things like alarm routing. What if we could route alarms to the closest available caregiver rather than to the nurse who's gowned up in an isolation room? So we eliminate or at least get rid of most delays in response. And you also asked around patient monitoring, right? So I think the newer technologies, first of all, there's more care appropriate monitoring. So, GE has released a platform called Portrait Mobile, which is leveraging these Internet of Medical Things sensors. So now I don't have to necessarily wheel this monolithic piece of hardware up to every bedside. I can provide the sensors people need. So rather than just simply slapping a bunch of ECG leads on a patient and then having to deal with all the alarms that generates, I can be more appropriate in what we're monitoring. And I can flex the acuity of these platforms. And overall, these technologies are really giving time back to the clinical staff. And with all the aging population, increasing demands, right, these solutions that focus on giving time back are going to be the ones that make the biggest difference.
Great, thanks, Angus. With virtual care models expanding, how can centralized surveillance leverage some of these emerging innovations?
Um, well, let's start with, first of all, centralized surveillance can complement virtual care by providing really real-time monitoring of patients at home. Using data from wearable devices, these telehealth platforms can alert healthcare providers sooner, and this integration allows for proactive intervention and better resource allocation. And specifically around the home, right? Virtual care at home is transforming patient care by enhancing access to caregivers from the comfort of their home. Sorry. They can significantly impact folks who have social determinants of health challenges, such as transportation. And by enabling ongoing monitoring support, we can better manage chronic conditions and reduce hospital readmissions. And I'll give you one example. In the US, about 40% of heart failure cases are not diagnosed until the point that the disease has caused symptoms that require immediate care. And that's because many patients don't have access to a specialist due to shortages of trained professionals, as well as those social determinants or their location. So can we leverage, AI to enable guidance to less experienced caregivers in the home to provide, say, ultrasound imaging and other diagnostics right there in the home to address that? And can we tie AI to proactively monitor that vast array of Internet of Medical Things devices that are now available? So shifting care to home environments will really benefit from these technologies and the evolution of technology.
Right. Awesome. Keith, do you have any thoughts anything you'd like to ask Angus or, please feel free.
Yeah. So a few things. So Angus, I guess, as say thinking about this from the nurse's point of view,
Mm-hmm.
looking at all of the technologies that are part of their world, do you ever hear anything back from them about, are they losing some of the in-person, some of the personal, so that if we have more like technology intervening, do they miss opportunities to really provide that in-person care?
I think the biggest aspect of the in-person care is how the technologies are driving their workflow by constant interruption. So that's one of the purposes of surveillance, isn't so much to send more, is to send less. And to give you a couple examples, for instance, one hospital system in South Carolina decreased their total alarms from a peak of 350,000 per day to about 200,000. So that was a decrease of over 40%. At one of the Baptist hospitals, after we went live with them, they had a 50% reduction in alarms sent to caregivers and about a 50% reduction in the amount of time patients spend in alarm. Another example would be HCA, I think. They published something in the AHA journal. Now, their initial motivation at HCA was around risk reduction, because one of the other areas that is a symptom of nursing overload are unmonitored patients. So my patient's leads are off over here in this room, but I'm busy with something more important here. And then they forget that the leads are off, and then they come in there later and something's happened to that patient and we weren't able to monitor it. In fact, in some of our earlier initiatives in Florida, we did a study of it's like over 500,000 alarms, and we found that 70% of sentinel events lived during unmonitored time. So we're finding that we're also decreasing the time patients are in an unmonitored state and making sure that, that we're not flying blind with these patients and we're reducing risk. But also as part of HCA's motivation, they published their metrics in AHA journal for 6 hospitals over the course of about a year. And they found that alerts to clinicians decreased from over 5,000 a day to just over 3,000. So they had a more than a third decrease in alarms. Time in alarm also decreased. And they also found that alerts handled by clinicians, and this is really interesting, rose from 32% of alerts being handled to 79%. So they had an increase of 88% more alerts were handled by nurses. And that's the reality of healthcare. Nurses get more alerts than they can handle in a day. But you should note those HCA metrics are not before surveillance and after surveillance. They already had a surveillance operation. They were using their clinical communication platform and were manually communicating. The tools we added there to digitize all those workflows and the tracking of response so these differences were really the before and after of adding the digital tools on top of that. But starting from scratch, we see even greater decreases in interruptions, ranging from probably 60 to 80% reductions typically.
So then I guess if we're talking to nurses, I guess, or what are you hearing from them if you're giving them more time in their day back and they can be more efficient with their time? What are the things they want to use that time for? What do you hear from them?
That's a vast speculation by hospital leadership of what they'll do with that time, but I think they're going to provide better care. Honestly, they can be more deliberate in their care, because every time I get an alarm, if somebody's not curating that alarm to make sure it's real, I have to jump out of the room every time I see a VTAC or a asystole, and the majority of those, unfortunately, in healthcare are false because of the vagaries of skin prep and quality of electrodes and patient movement and disconnects. So the challenge is that most of the time that I have to jump out of a patient room and leave the care that I'm providing, I didn't have to. And so you can imagine the frustration level of nurses. So they're ecstatic about it. And on the virtual nursing side, GE has a virtual care platform, and we've also seen leveraging central surveillance as part of virtual nursing at a major teaching hospital in Houston. They actually recognized they had this challenge with nursing experience, and again, nurses being so busy they're not necessarily staying on top of patient deterioration. So back in, I think, 2018, 2019, they deployed this virtual technology to provide surveillance capabilities to a couple of experienced nurses. So 2 experienced nurses are sitting up in a room upstairs in the hospital monitoring 400 patients. But they're not watching 400, they're watching the ones that an algorithm says, hey, pay attention to these patients. And then what they do is they use our clinical decision support tool to assess what needs to be done. And often they would call the rapid response team before the nurses on the floor realize the need to do that. But they are passionate about the lives they've saved. And also they cut in half the number of rapid response calls that ended up having to be transferred back to ICU. So they went from 34% of rapid response calls ended up in an ICU bounce back to 17%. And this result has held up consistently for about 4 or 5 years. So that dramatically impacts length of stay, mortality, outcomes, everything. And I think the nurses appreciate having that extra set of eyes behind them. HCA Continental Division was doing the same thing with a different system, and they were actually trying to work toward allowing nurses to work at home. Because think of the domain knowledge of all these nurses that have resigned. Some of them just couldn't physically do the demands of the nursing job any longer, but could we take what's up here and allow them to still use that to improve care? And that's another thing that we can do with these systems now.
So another aspect of what you talked about I thought was really interesting from a design, say, systematic perspective, the hospital to home model. So I guess if you were going to speak to the topic of, let's say you mentioned ownership and how to prioritize. So if, say, you were going to empower nursing to, let's say, deliver that message that a hospital at home or hospital to home model could really be cost effective and, say, better for the patient, what could they do along the journey to help encourage that as they encounter patients?
What can hospital leaders do as they're in terms of leading and having ownership of these systems?
Yes.
Well, that's a good question, because I think staff on the floor are fine with sending these patients home. I think it's getting everybody on board with it. Even one of the simple things we get involved with, not so much home, is telemetry cessation. People, almost as a reflex, throw them on a telemetry pack, and there's sort of this security blanket comfort in keeping them on monitors when they don't necessarily need to be monitored. And I imagine it would be the same thing around sending patients home. So, but I think that's necessary because the biggest benefit of that hospital to home is freeing up beds, because we've got patients boarding in the emergency room or in PACU, and we want to get them up to a floor. In fact, even the cost part of that, I mean, I think it's about as expensive to board a patient in emergency as it is to put them in a critical care bed, when all they needed was a lower acuity inpatient bed that costs half as much as boarding them in the ED. So I don't think necessarily have to convince the caregivers at the bedside so much, but I think we need to convince the hospitals to embark on these programs.
Excellent. Thank you.
Well, Angus, I'd like to thank you for sharing your time, your insights, and your perspectives. And also our sponsors, Storage Systems and Simplified Medical, have made this conversation possible. Angus, do you have any final thoughts for our audience members who are looking to transform their centralized surveillance or virtual care strategies?
Well, at the risk of having a shameless plug, I mean, certainly we would love to talk about lessons learned. We've done it really more than anybody else has done it in the field. And the thing that makes what we do special is this outcomes delivery team that we built, because it's again, the technology is absolutely important and we've done a lot around that, but it's the ability to deliver this that's key. And we'd be happy to share, from lessons learned and best practices that we've seen in the industry. But I think it's just really talking to your people and understanding their challenges and how can we solve that by providing these backup layers of support for them.
Thanks, Angus. Well, I certainly learned a lot from today's session. My key takeaways were about centralized surveillance and virtual care, really posing a huge opportunity to revolutionize the whole healthcare landscape. It seems that these technologies you've outlined, especially the stuff around AI, really provides an opportunity for a more connected and immediate focus on the patient's needs, regardless of whether they're in the facility or remote. So thank you for a very informative session. Keith,
Really
give me
appreciate the opportunity to meet with you all today.
Great. Well, we definitely hope to get you back here. Keith, do you have any final thoughts that you'd like to share about today's session?
Yeah, Greg, thanks. And thanks, Angus. I want to thank you for your sharing your expertise. I think this approach of enterprise class technology leadership to drive standardization is really an important conversation. I think there's the things you shared, there's just a lot of valuable insights about how to focus on processes and streamline clinical efficiency, really to improve patient outcomes is spot on. I also want to thank our audience for joining us today on this journey to Beyond the Blueprint. I think it's really great we have these conversations, and that by focusing on centralization and platforms, you really can get to these places of better care coordination, more patient-centered care, and you can spread that across your organization. So, Angus, I look forward to maybe having you back and sharing more success stories and going a little bit deeper on this topic in future episodes.
We've got a lot of success stories, so we would love to.
Great.
Thanks, Keith. Angus. For audience members who are not familiar with us, Spyglass Consulting is a product and go-to-market advisory firm focused on emerging technologies and growth opportunities within the healthcare and life sciences segments. We proudly serve more than 250 leading entities that are technology companies, management consulting agencies, healthcare providers, and investment organizations. We've published more than 30 market research reports on a diverse set of informatics-related topics. To access our extensive library of paid research and to gain deeper insights into how technology is reshaping healthcare, I invite you to visit my website at www.spyglass-consulting.com. Well, I think that's a wrap for today. Angus, once again, great episode. And to our viewers, stay tuned for our next episode of Beyond the Blueprint.
Thank you.
Thanks, everyone.
Thanks.